So we have been chatting about how quite commonly in supervision we have people bringing to us concerns about the child that they have had referred to them is not the child they see in the therapy room. And they've gone through the process of obviously doing the referral meetings and the intake meetings, and they might have had a child who's been referred for aggressive behaviours and for acting out. And they bring the child into their therapy room and it is a completely different presentation. They're calm, they're looking for connection, and I think that for some therapists this can feel quite destabilising. They're expecting one child and they get a completely different one.
I would agree with you, and I think that therapists can get very, very anxious about that, very, very worried about that. And it's really hard, isn't it? We know ourselves when we have that information to place it on that invisible shelf in our head and to be thinking and feeling what's going on here. And we can't undo what we know.
No, we can't. And I think that although one of our tenets is to accept the child for who they are, I think we commonly think that that needs to be accepting upregulated or difficult behaviours, but actually accepting that a child might be okay with you can sometimes be quite worrying, because the therapist is then left thinking, well, what's my job? What am I working with here? This child seems fine.
Yes.
But actually, if we think about the overall point of therapy, it is relationship.
Yes, the therapeutic relationship.
Yeah.
And the thing about therapeutic relationship as well, it has to be established. And it may well be that the child starts to behave slightly differently as the therapy moves on.
Exactly.
And we may see some of those elements that are the reasons for referral. But as you say, often that doesn't happen.
Yeah.
And there is a reason for it, right?
Yeah.
We know that there's a reason for it. And that would be about co-regulation.
Exactly. So thinking about the fact that if you have a child who in a classroom setting or in a family setting is very upregulated, uses protective behaviours that may be aggressive, if they're in this one-on-one basis where they're being given room and space to do what they need to do, they don't need to utilise those protective behaviours. And so that's hugely rich information for us to then share with parents and professionals outside of the therapy room. And I think that's another anxiety people have, is how do I go to a meeting where everybody else has experienced this very dysregulated child, and actually we don't see some of that. But it's brilliant because you can then say, well, is it that this is what this child needs a bit more? Are they looking for connection and they don't know how in what feels like quite a chaotic environment?
Yes.
But in this environment, they actually do really well. So I think that that's a really important thing for people to be able to take away and offer up.
And I think the other thing is to really be thinking about that time-limited therapy is often not going to work. Perhaps with more complex children who are presenting very differently. With you in comparison to in the environment, because what we know also about the kind of the brain structure, if you like, and the neural pathways and the neurons is that there needs to be consistent repeated experiences which are to the positive and not to the negative. And therefore, from our point of view as therapists, it's really important that we can establish a contract, if you like, with organisations that are more than 12 sessions.
Because this isn't going to be a short-term piece of work.
6 sessions is not going to be enough to, if you like, to support that change in the neural pathways in that brain functioning.
So what happens if there is no capacity for longer-term therapy? Well, I would argue that then it becomes a piece of work that the therapist has to do to educate and support other professionals that actually, okay, I can't do this piece of work. I'm only with this child 40 minutes a week. If we can get established on the outside a little bit of what I'm offering on the inside, then hopefully some of those reorganised neural pathways can happen as well.
Yes. And I do think it's an opportunity for therapists to be offering training, be offering some psychoeducation, to other professionals, and to get something in the environment that's slightly different for that child, which perhaps parallels some of the things that we're offering in therapy. What I mean by that is perhaps a safe space, some different sort of nurturing responses and nurturing techniques, and some active listening, which I want to acknowledge can be very difficult in very, very busy environments. But those are maybe the things that one could be thinking about.
100%. So briefly, if a therapist does find themselves in the position where the child that they have been referred is not the child that they see, relax into it.
Yes.
This is what you're working with. And actually the child is offering up potential that they are looking for co-regulation, which is what we are always looking for all the time. We need it. And that it doesn't mean that you're not working with the core issue. What you're doing is building foundations for relationship, you're changing neural pathways, and you're also getting fantastic information for people outside of the therapy room of what they might be able to provide differently for the child.
Yes. And I think the last thing that I'd like to say is that what it also shows is that the child is expressing different parts of them, and that they don't, it's the reason for the referral is a part of them, but how they are with us in therapy is also a different part of them, and that offers the potential for that part to be seen outside, but it needs to be tapped into a different way, and that means that there's always that potential for that child and that opportunity, hopefully.